Please go.
Dr. Anshika, yes, thank you. She'll be presenting on a case, tuberculosis unmasked by unilateral solitary choroidal granuloma, a rare presenting feature.
It's not working. Good morning, everyone. I'm Dr. Anshika, and today I'll be presenting a case that presented to us with ocular tuberculosis. So this patient was a 24-year-old male patient with complaints of decreased vision, with distortion of image for 15 days in his right eye. It was gradual and progressive. He did not have any history of trauma, floaters, pain, or redness. There was no significant drug history, no history of any constitutional symptoms, difficulty in breathing, and he did not have any history of high-risk behavior. He had a family history in his father of TB, who died because of TB-related complications around 8 years back. On examination, his BCVA in the right eye was 6/12 and in the left eye was 6/6. He did not have any RAPD. The pupil was round central, 3 mm, and normal direct and consensual reflex in both the eyes. On fundus examination, he had a single large subretinal round mass which was encroaching the fovea, and there was also there was also associated significant disc edema in both his eyes. So you can see there was a single very large choroidal granuloma probably in his right eye, but what was unusual was a bilateral disc edema in this patient, which was symmetric, and this is a picture of the right fundus. Optic disc cube of both the eyes also showed an optic disc edema, and these were the OCT pictures of the same patient. This was the left eye. He did not have any changes in his macula. There was just an optic disc edema that was present in his left eye as well. So our differentials were papilledema, optic neuropathy, sarcoidosis, syphilis, and other infections such as toxoplasmosis, toxocariasis, vasculitis, multifocal choroiditis, and AMPPE. This was the visual field that was done to rule out any neurological fields. This patient, the initial battery of investigations that were ordered were CBC, Montu, and chest X-ray, because we had a high suspicion of TB, followed by ESR. A neurologic consult was done, and MRI, brain, and orbit were also ordered, along with quantiferon TB, and then all the other differentials were to be ruled out, so we ordered further investigations. This patient had a positive Montu test. ESR was increased, chest X-ray was within normal limits, and MRI, brain, and orbit were unremarkable. His quantiferon TB gold was positive. So these were his MRI, brain, and orbit, which T1, T2, and flare sequence were done, which were completely unremarkable. So this patient was started on anti-tubercular therapy along with adjunctive oral steroid to mitigate the granulomatous inflammation, and we had a dramatic improvement. So this was a 4-week follow-up of this patient. We can see that there was a significant reduction in his granuloma, but the disc edema still persisted upon subsequent follow-ups as well. On 4 weeks follow-up, the exudative retinal detachment that was initially present was already in the resolving stage. The disc edema persisted for about 4 to 5 months in this patient, and even on we followed this patient every 2 weekly. Then finally, at 6 months followed up, we can see this fundus image, which is showing the resolving disc edema in this patient. And a guided progression analysis was also done, which shows 6-month reduction in the disc edema in this patient. So intraocular TB, it can have many presentations, most commonly presents as posterior uveitis. There have been multiple cases of optic neuropathy, and this was a case which we diagnosed as intraocular TB with the solitary choroidal granuloma in the right eye with bilateral papillitis. With bilateral papillitis usually have been reported only unilaterally in multiple cases. Bilateral presentation is quite rare. Only 10 to 15 case reports have been there so far, so because of lack of time, I'll just brush through this. There have only been 10 to 15 cases reported globally, which were bilateral tubercular papillitis. Most of them had also bilateral choroidal tubercles. This case had a unilateral choroidal tuberculoma with a bilateral papillitis because of it.
So any vasculitis that you have seen on angiogram, if not detected clinically, even that can be the reason why the patient had this papillitis?
Yes, ma'am, he did not have any signs of vasculitis
on clinical examination. But what on FFA you can still make out?
Ma'am, we did not do an FFA for this patient. We already had a very high clinical suspicion of ocular TB. So
no, I'm telling you that can be the reason for your optic neuritis bilateral.
Yes, ma'am.
Did you get what I'm telling you?
No.
Ma'am, do you agree? Or tuberculosis can itself present as optic neuritis, like in this.
Yeah, your question is with an optic disc edema, FFA would have helped.
FFA, because she said that there is no multifocality of the lesions in the fundus, in both the fundus. Only one tubercular granuloma that can result in disc edema in that particular eye. But the disc edema and congestion in the other eye, there are no other signs.
Yeah, I agree.
Of tuberculosis.
Yeah, that's right. I mean, yeah. See, vision was normal to answer your question whether I agree about vasculitis. See, most of the time we should be able to pick it up clinically with a dilated exam. So probably I would not advise an FFA just to diagnose vasculitis, but if you're trying to document a case properly, yes. But for clinical management, probably if I don't see any signs of vasculitis, no cells, no vascular sheathing, no hemorrhages, probably I would not do it.
But the reason why the other optic disc is also
that part. So you said the vision was normal in the other eye.
Yes, ma'am.
Even color vision?
Yes, ma'am.
Yeah, so it's very, very unlikely to have optic neuritis with having normal vision, normal color vision, normal pupils. So, but it is there obviously in your case. So
yes,
we don't know maybe it's a tubercular bilateral papillitis. We have to accept it, but without any functional changes in the optic nerve.
Yes, ma'am.
We have to accept it. Otherwise, I would have said, if it had not improved subsequently, I would have said it's pseudopapillodema, which is common in so many people.
Yes,
they have an appearance of disc elevation, but it's not really.
It has resolved actually.
But it resolved.
Yes,
but it did resolve. So
yes,
then we have to just not think about that. But more importantly, let's come to some other things. Very well managed and very well treated. But how often is chest X-ray going to be useful and compared to CT chest? So nowadays, at least I have completely moved to CT chest because chest X-ray never gives any findings, whereas CT chest almost never not gives any findings. Always you get some sequelae of something or the other, some scar, some fibrotic lesion, some apical lesion is there, whereas chest X-ray never gives you anything.
Yes, ma'am.
So I think it's better to do chest CT as far as possible, though the only downside is exposure, radiation exposure to the patient. That's a downside, but generally it gives some guideline, I would say. And you also had TB Gold positive.
Yes, ma'am. Quantiferin was positive.
Which was very good. But you know, we don't even need these tests to be positive if we are clinically certain about our diagnosis.
Yes, ma'am.
Even in the absence of these tests, absence of any tests actually, we see repeatedly that if our clinical judgment is very strong for TB, there is no harm in giving an ATT trial,
yes,
and most of the time it does work. But if you are trying to use it as an ATT trial, probably best not to give steroid at the same time, at least for 1 or 2 weeks. And in your case, it was not vision threatening. It was away from the center. So possibly so that otherwise we don't know whether steroid is working or ATT is working.
Yes, ma'am.
So if you're trying to do a therapeutic trial, probably it's better to withhold steroid if it's not vision threatening.
And these are very characteristic clinical signs of tuberculosis. So we can still try with only ATT. There is not this is not an unusual finding.
Yes, ma'am.
So definitely, as Madam said, we can definitely go with a trial ATT.
Yes, ma'am. Ma'am, his ATT was started within 1 week of his presentation.
Even without steroids, oral steroids.
Yes, ma'am. We started the steroids a week after the ATT was started.
So now the recent evidence shows that only ATT can help. You don't need to put the patient on steroids at all. What the Madam's cases were previously. She didn't.
Every case does not need steroid, frankly.